Okay. Well, good evening, and thank you for joining the Public Health Museum's World TB Day presentation. My name is Catherine Demoto, and I'm the president of the museum's board of trustees. In the past, this event would have been held at the museum at Tewksbury, Massachusetts, but due to COVID, we have now embraced virtual technology, and with that, we are reaching out to a wider audience. Many thanks to Carrie Nagel for technical support, Paige Impink and Ashlyn Rickford for very successfully spreading the word about many museum events. So for those of you who are not familiar with the museum and have not been able to visit, I just want to take the opportunity to give you just a short background about America's first public health museum. The museum is a nonprofit organization located on the campus of Tewksbury Hospital in Tewksbury, Massachusetts. The hospital was founded as a state almshouse that opened in 1854, and it has been in continuous operation since then. The museum opened in 1994 and is located on the 900-acre state campus in a National Historic building that was built in 1895. The museum's mission is to celebrate the history and achievements of public health. The museum preserves the past, inspires future practitioners, educates the public, and advances the future of public health through partnerships with academic institutions. We have so we could go to the next slide, a wide collection of historic public health artifacts and documents, which are exhibited in 6 different rooms in the historic building. And we very much invite you to come and visit them. One of our programs, which is now in its 9th year, is Outbreak. It's a free program that is offered to high school students in August with the intent to interest them in the public health career. Now you see on your screen, next week, we have Public Health Week is coming up, and the museum will have 2 virtual presentations, as you can see on the screen there. And then in addition, we'll have trivia night on Friday, and we hope you'll join us. We have tours, and unfortunately right now they're limited, but you still can sign up via an appointment, and you would benefit from a very interesting historic overview of public health. So if you could visit our website, publichealthmuseum.org, for more detailed information, including visiting hours, events, and exhibits. And then you can come see us sometime. Now I will turn to Dr. Al DiMaria, a museum board member and former state epidemiologist and medical director of the Bureau of Infectious Disease and Laboratory Sciences, and he will introduce the speaker, John Bernardo. Al?
Thank you, Kathy. Good evening, everyone. And today is World TB Day, a day when we stop and think about the impact of tuberculosis in the world, the #1 infectious disease cause of death. And it causes serious illness in literally millions of people each year. And tonight, we're especially happy to have one of the world's TB experts, Dr. John Bernardo, who is professor of medicine and research professor of biochemistry at the Boston University School of Medicine. Dr. Bernardo has a distinguished career. And you know, I realized something today. He does bench research on white blood cell activation. Those are the cells that go after bad things that try to infect you. He treats patients with TB and all manner of pulmonary disease. He attends in the ICU, so he does critical care medicine, and he also does allergy. So he has, I had never thought about it before, but he has the whole respiratory tract wrapped up. Mm-hmm. And so we're very happy to have him here today. He's been the tuberculosis medical officer for the Massachusetts Department of Public Health for couple of decades now. He is past president of the National TB Controllers Association. In fact, he was president twice, president of the National Society of TB Clinicians. He's on the board and was chair of the Stop TB USA organization. He's been on Association of Public Health Laboratories and federal panels, and has been principal investigator on the TB Trials Consortium, and with the Department of Public Health, the TB Epidemiologic Studies Consortium. So it gives me great pleasure to introduce Dr. Bernardo. We're going to, you can put your question, I'll be checking both the Q&A and the chat. So you can put your questions in there, and then we can get into a question and answer period. Unfortunately, I should have brought a picture of Dr. Bernardo to put up, because computer he's at now doesn't have a camera. But just imagine what he looks like and give him a warm welcome. John.
Well, thank you, Al. I'm very, very pleased and honored to be here today in World TB Day to speak with you folks about tuberculosis, which has been an important part of my life. I'd like to start out by telling people what tuberculosis is. It actually is an infectious disease, and it's endemic in the world today. As Al alluded, it is the leading infectious killer of human beings today, outside of COVID. And when you think about it, TB has been responsible for the deaths of more people over time than any single infectious disease in the world. And it's largely because there's a reservoir of infected persons who become ill with TB and can spread it from person to person through the air. TB is not very contagious. It's not like the flu or COVID, where you need a casual exposure. You need relatively lengthy exposure in a closed environment to transmit TB to another individual. In this picture on the bottom, there's Dad in the chair who's got TB and doesn't know it, and he's coughing. And if you've read any of the COVID literature, you know that coughing produces these little droplets that go out into the atmosphere. These droplets land in the lungs of the naive persons in the room, that is, people whose immune systems have never seen TB, like these kids who are sitting around Dad. And it enters the lungs, where it encounters the innate defense mechanisms that are designed to kill the organisms and clear them from the human body. However, the bacteria is very smart. It's learned how to evade killing. And so it goes down into the lungs, gets taken up by these scavenger cells called macrophages, and it gets cleared in through the bloodstream and lymphatics throughout the body. But the bacteria are not killed. They're still alive in the macrophage. The macrophage does something else. It creates a process whereby the person becomes sensitized or immune to tuberculosis, in a sense. And that really means that the body's immune system will be able to recognize TB. And that process takes up to 8 weeks. And during that time, the bacteria are migrating throughout the body and wind up in different parts of the body and then get contained by the immune system. And this is called latent TB infection. And about 25% of the world's population is infected with TB in this form. I've got latent TB infection. Later on in that person's life, could be months, days, months, weeks, or decades. One of those or more of those sites where the bacteria are contained will break down and produce active disease. It can happen in any organ, but it usually involves the lungs or the airways. And that's the most common form for 70 to 80% of cases of tuberculosis. And these types of TB are then infectious, where that person can now cough and spread TB if he's got TB to the lungs. This happens in about 7 to 10% of people who are infected with TB during their lifetime. So TB may be difficult to diagnose because the signs and symptoms are similar to lots of respiratory diseases. So you have to think about it. The important thing is that it's treatable, and the disease is amenable to treatment with medications, and importantly, it's preventable. And I'll get into that in a few minutes. Well, TB's been with us for a while. It's been found in mummies in Peru on this side of the Atlantic and in Egypt. It has permeated art and music throughout the centuries. This picture on the left is a figurine of a male with a hunchback deformity, likely caused by tuberculosis of the spine. The TB organism, when it affects the spine, usually affects the parts of the vertebra we call the vertebral bodies here, which then collapse because they're infected and then cause this deformity. Okay, this figure dates to about 3000 BC. Now there are other diseases that can do this, so it's not conclusive that TB caused this, but it's very likely. In 1993, Salo and colleagues published this paper where they showed using PCR techniques or molecular methods that they could identify Mycobacterium tuberculosis DNA in a pre-Columbian mummy from Peru, showing that the organism was present in Peru for at least 550 BC and before. And that was before Columbus. So we know that Columbus or Western people didn't bring TB to this side of the Atlantic. So before 1900, most people in Europe were affected with TB, and TB was responsible for 1/4 of all deaths. There was no understanding of the etiology or the pathogenesis, that is what caused TB. Fracatoro proposed transmission of TB by an invisible virus in 1546, and people were skeptical. And 100 years later, Villemin demonstrated that tuberculous matter from a human cadaver injected into laboratory rabbits can cause infection in that rabbit, suggesting there was something transmissible. But it was generally thought to be hereditary and related to squalor and malnutrition in overpopulated areas like the Latin Quarter of Paris. In fact, there were music and art and literature that depicted TB. And La Boheme is an example of this, where the protagonist here, who is Marilla Freni, is dying with tuberculosis and eventually dies of it. And the whole picture of tuberculosis was romanticized in literature and music through that time in this way. Many important and famous people had tuberculosis. John Keats, the Romantic poet, was a physician, and he died in his mid-20s from tuberculosis after being ill for only about a year. Robert Louis Stevenson, in contrast, developed tuberculosis, and he died at the age of 44 after having TB for many, many years, and being treated by methods that were used in those times, including visits to sanatoria like Davos in Switzerland and Saranac Lake in New York. The Bronte sisters and their brother, 6 in all died of tuberculosis. The youngest one was 12. Youngest sister, Maria, was 12 when she died. And their brother and one of the sisters died within 3 months of each other, all from tuberculosis. Vivian Lee, in more contemporary times, suffered from tuberculosis, but she refused all treatment, and she eventually succumbed to the disease. But, you know, progress is slow, And back in those days, like I say, people thought tuberculosis was something that was related to malnutrition and squalor, and may have been passed on within families. It wasn't until March 24th, 1882, that is today, in 1882, World TB Day, Robert Koch presented to the Berlin Physiological Society a paper that disclosed that the disease was caused by an infectious agent, which he called Mycobacteria tuberculosis, that he could identify. He published this as a paper about a month later. And this set up the principles by which we now try to use to confirm a causal relationship between a microorganism and a disease. And these are listed here, and they're fairly well recognized today, although there are exceptions. The microorganism must be found in the diseased person, but not healthy individuals. The microorganism must be cultured from the diseased individual. Inoculation of a healthy individual with a cultured microorganism must recapitulate the disease, excuse me, and the microorganism must be re-isolated from the inoculated diseased individual and matched to the original microorganism. And so this process works for many bacteria, but not for things like viruses or even tuberculosis. When you look at the first example, because microorganism can be found in people who are not diseased. As I mentioned, 25% of the world's population walks around with latent tuberculosis infection, but they're not ill. In 1890, after more work in his lab, Robert Koch thought he had a cure for tuberculosis when he boiled the culture of tuberculosis and filtered the fluid or the supernatant liquid that resulted. And he was able to inject that into animals and prevent them from getting ill from tuberculosis. So he thought this was a cure for the disease. He tried doing this in humans and it made him sick, and it really was ineffective as treatment. But gradually, it was recognized that it's useful as an indicator of infection. And so this test that was developed in 1890 can be used to test whether a person is immune sensitized to tuberculosis, according to the reaction that occurs when it's injected into that person. And in fact, this test is still widely used today with few modifications. In 1895, a major event occurred in TB work when the X-ray was discovered by Röntgen, and that helped us out a lot. So in those days, tuberculosis was basically based on suspicion on the clinical picture of the patient and the environment that you were in. The symptoms of tuberculosis can be diffuse, and they're usually related to the site of involvement or the organ of involvement with the disease. These include fevers, night sweats, cough, bloody sputum, weight loss, back pain if you have TB of the spine, bloody urine if you have TB in the urine. And in those days, those symptoms were sufficient to make the clinician think about tuberculosis as a possible or likely diagnosis. There was very little understanding about the transmission of tuberculosis. Then came radiography, which was a big help because TB of the lungs, as I'll show you, can have clear manifestations, although they're not specific to tuberculosis and may be seen with other diseases or infections. One of the other things that that Koch came up with was the smear for tuberculosis, where you could actually visualize these bacteria on a microscope slide, and you could perform this stain on sputum, on fluids, or on biopsy specimens of tissues from organs. And by the way, the smear microscopy of sputum is still the most common way to diagnose TB in the world today, despite our scientific advances. And now there's also culture with growth of the bacteria, which Koch discovered. And the fact that the bacteria can be cultured is fortunate, but unfortunately, it grows very slowly. And it can take up to 8 weeks to grow in culture. The X-ray, as I mentioned, was a powerful tool. And in the early days of tuberculosis in the 19th century and 20th century, actually, the chest X-ray was used as a screening tool for tuberculosis. And we had vans going around like this that were used to diagnose tuberculosis. Where the disease is very endemic, it's a relatively efficient way to diagnose it, although it's not very cost effective. And London recently purchased several of these vans to screen populations for tuberculosis at tremendous cost. So by the turn of that century, antibiotics were not yet invented, and treatment was based on rest and nutrition. These sanatoria were created. Maybe some of them you recognize: Saranac Lake, New York, where Trudeau had his sanatorium, or Davos, Switzerland, which is now a big ski resort down in the mountains, and Sunshine. Yet death rates approach 50%. And this is a slide of sun therapy for tuberculosis that was used in 1927. Isolation was not commonly practiced because the principles were not widely accepted, that the disease could be transmitted from person to person. Lung collapse therapy was an interesting approach, although it could be painful and strewn with complications and disfiguring. First of all, thoracoplasty was invented or started to be practiced in the late 1880s, where it involved major surgery to collapse the lung, involved part of the lung that was infected with tuberculosis and causing disease. The reason for doing this, and the reason it may have worked, is not clear, but it involved major surgery where the ribs were resected. Then Tuffier in 1891 started putting lucite balls or wax or other materials into the pleural space between the lung and the chest wall to collapse the lung without removing ribs. And that was used for a while. And in 1888, Forlanini tried inducing a pneumothorax, which is basically pumping air into the chest cavity between the lung and the chest wall to collapse the lung. And it was controversial, but very commonly done. It was less disfiguring than thoracoplasty or the other surgical procedures. And in fact, resulted in a Nobel Prize nomination for Carlo Forlanini in 1914. So this is a normal chest X-ray. And what you see is the heart in the middle, the blood vessels, and airways coming out from here, the lungs here, and the chest wall and the ribs here. This is a typical X-ray of somebody with tuberculosis that involves the right upper lobe. The disease classically appears this way, and for some reason, TB likes the upper lobes, right or left upper lobe, or the superior segments of the lower lobes. So this is what we would call a pneumonia. And 2/3 of pneumonias caused by TB are either in the upper lobes or the superior segments of the lower lobes. But fully 1/3 of tuberculosis can happen anywhere in the lung. The pneumothorax, that is the collapse of the lung, involves introducing air into the space between the chest wall and the lung. So the lung collapses due to elastic forces. And this was the principle behind a therapeutic pneumothorax for tuberculosis. In this case, would involve left-sided pneumothorax for somebody with TB in the left lung. This is a thoracoplasty, where you see the ribs are removed and the chest wall collapses. It can be quite disfiguring, and it's a complicated operation. Now, these are lucite balls that were put into the pleural space during surgery to collapse the lung. And this is another picture of a plumage with lucite balls here. And this is a CAT scan that shows these lucite balls within the patient's lungs. And again, nobody knows if or why these were effective, but they were widely practiced. In fact, a pneumothorax machine was widely available, where the physician would pump the air into the chest cavity to collapse the lung. Here, it's being shown in the 1940s. And this is an example of one of those machines, and we have one of them at the Public Health Museum. Now, this is an interesting slide. This is a slide that I obtained from Boston City Hospital as the buildings were being taken down. And it shows the causes of death during the year 1900 in the city of Boston. And the leading cause of death is here on the left side, and it's pulmonary tuberculosis. Down here somewhere is TB meningitis. But tuberculosis was the leading cause of death at the turn of the last century in the city of Boston. But then came antibiotics, but it wasn't until 1945 when Waxman published his work on streptomycin that eventually won him the Nobel Prize. That same year, Lehman announced the effectiveness of PAS, or para-aminosalicylic acid, for treatment of tuberculosis. These medicines were effective, but they were fairly toxic and difficult. And treatment of tuberculosis with these medicines was very, very lengthy. It involves more than a year and more like 2 years of toxic treatment with these medicines. In 1948, pyrazinamide came along. In 1951, isoniazid, which is one of our mainstay drugs. 1961, ethambutol, and 1966, rifampin. The treatment of tuberculosis now is much less involved and less disfiguring than it was at the turn of last century. And it involves taking medications. But usually you have to take multiple medications, at least 4 to start with. And we usually start with INH, rifampin, pyrazinamide, and ethambutol. Why multiple drugs? Well, because if you use a single drug, the bacteria quickly develop resistance to that drug. So you need a second drug in there to catch those bacteria who spontaneously become resistant to the drug. Treatment requires close clinical and laboratory monitoring to make sure the patient has the medications, is taking them correctly, and is not having side effects from the medications, because all these medications have toxicities and side effects. Length of treatment now is at least 6 months, but it may require 2 years or more. The important thing is that the disease is reportable to the State Department of Public Health for both cases and for persons who are suspected of having tuberculosis, so we can intervene with the Public Health Department to deliver patient-centered nursing case management. And this assures that the patient takes his or her medicines correctly and completes therapy safely. And then there's a commitment to treat patients with tuberculosis, not just to cure the patient, but to protect the public's health and make specialized care available. And so the state has funded and it continues to support state TB clinics and specialized TB services at the Lemuel Shattuck Hospital for TB. What about prevention? I mentioned that TB is a preventable disease. Well, the risk of developing clinical tuberculosis if you're infected is about 5 to 10% over your lifetime. The risk goes up to 5 to 10 per year if you're infected with HIV. Most of the risk is in the first 1 or 2 years following the initial infection, but it can occur at any time throughout that person's lifetime. So I was infected when I was younger, but I still carry that risk of reactivation and becoming sick with tuberculosis that I contracted when I was younger. In fact, most tuberculosis in the United States and Massachusetts results from reactivation of latent TB infection. So, but we have treatment using these bacteria that kill the bacteria that are contained by the immune system in people like me with latent TB infection. The public health benefits are obvious. They cure they prevent the future cases, and they're key to TB elimination, since 80% of our cases in the US result from reactivation of latent infection. Getting programs that work to deliver treatment to people who are infected is key to TB elimination. What about a vaccine? We hear a lot about vaccines these days. And in fact, there is a vaccine for tuberculosis. It was discovered at the turn of the last century at the Pasteur Institute in Lille, France. They started working on it in the early 1900s. And they created a vaccine from a strain of bovine TB, which is a strain of tuberculosis that affects cows, that failed to produce disease when injected into animals. And they called it BCG. First used in humans in 1921. And it's currently the most widely used vaccine in the world. We don't use it in the United States. And its efficacy is in question, but it's largely restricted to preventing disseminated disease in young children. Children under 5 years of age handle the bacteria differently than older people do, because their immune systems are not developed sufficiently to manage the bacteria correctly. So the vaccine tends to work to prevent young children from getting TB. That can be devastating and even fatal. So what about public health and its investment in tuberculosis? Well, TB was not a reportable disease, and it was not tracked until 1953, when the National Surveillance System was established for reporting new cases of TB disease. At that time, the case rate in the United States was some 53 cases per $100,000. The federal government also established categorical funding to support the federal government CDC agencies and state TB programs to deliver categorical TB services to their people. By 1984, the disease incidence had dropped steadily with this support from 53 cases per 100,000 to 9.4 cases per 100,000 at an average rate of 5.8% per year. So when we entered the early 1980s, we had declining rates locally, statewide, and nationally. The federal government had abandoned categorical funding to the states for TB control in the 1970s when they saw the rates going down, and they said, we don't need categorical TB programs anymore. So by the time 1980 came around, the states had block grant funding, and the states knew best what to do with the money, and it wasn't being directed to tuberculosis programs. And in fact, many states and municipalities were dismantling their TB programs. So when we look at 1984, there were 22,255 cases of TB reported with a case rate of 9.4 per 100,000, and there were 1,739 deaths. The technology was similar to those airplanes that I show in the picture here from World War II. Tuberculous skin testing was the way we tested for infection. Remember, tuberculous skin testing was invented by Robert Koch in the 1800s. So it's a 100-year-old test. The diagnosis of disease was based on growth on solid media and biochemical identifications, which are slow and laborious and difficult to apply to large populations without a lot of resources. We had gone from sanatoria, though, to outpatient treatment with self-administration of drugs, with an increased emphasis on patient supervision and education. Direct case management was not widely practiced at the time. We had 9 approved drugs, and we were encouraged to individualize our approach to each patient with at least 2 drugs being given for active disease to prevent the emergence of drug resistance. And treatment was generally 18 to 24 months. Once rifampin came along, we were able to reduce the length of treatment to 9 months and gradually down to 6 months for most cases of TB. The vaccine, well, we had BCG, but we weren't using it in this country. As I mentioned, the effectiveness of the vaccine was restricted largely to children under the age of 5 to prevent them from getting bad or serious types of tuberculosis like TB meningitis or disseminated TB. There was a regimen that we used to prevent TB, that is to treat people with latent TB infection, and that was using the drug isoniazid alone for 12 months. You could use one drug rather than multiple drugs when there was no sign of active disease, because the bacteria burden was low enough that spontaneous emergence of resistance was not a problem. In fact, in 1980, we had a state-supported and city-supported TB clinic at Boston City Hospital, and we each had assigned days at the clinic, and we were supported by public health nurses and outreach staff from the state and city departments of public health. And you know, as time went on, we saw a decline in tuberculosis in the US, as I mentioned. And if you take this curve, which shows the number of cases on the y-axis and years from 1980 on to 2004, if you extrapolate from the left side of the curve up to 1953, it's a straight line. So there was a steady decline until the early to mid 1980s when things dropped. And then along came AIDS. Well, as I mentioned, in the 1970s, they started taking apart TB programs, and there were categorical TB programs that were being dismantled. And then we were saddled with the burden of AIDS. We didn't even know what caused it, but we did know that there was a relationship between AIDS and tuberculosis. And as you can see here, the number of cases flattened off and then started to increase till it peaked around 1992. So what happened there? Well, there was a wide recognition that we were in trouble. This is a Newsweek cover from 1992, and it's an example of the public recognition of the disease, and it pointed out the problems that were pretty obvious to us in the business, but not too clear to our policymakers. This is an example of what happened in Boston. We had an outbreak of drug-resistant tuberculosis at the Pine Street Inn shelter for the homeless, where we had 3 cases of TB in the previous year, 1983. We had 19 cases show up in 1984. 50% of those cases were resistant to isoniazid and streptomycin, 2 of our TB drugs that were in use at the time. This is the Pine Street Inn. It's in the south end of Boston. It's the largest shelter for the homeless in Boston. And it was restricted to the men's side of the building. This is where the men sleep in these dormitories. You can see they're sleeping very closely to each other. And the environment is conducive to the spread of TB. The state supported a public health nurse, Barbara McGinnis, who was phenomenal. She was fabulous, and she developed a program with us to manage tuberculosis, diagnose it, and treat it within the shelter population. And over time, in this slide that shows both the number of cases in Boston and in blue, and in red, the cases in the shelters, largely Pine Street, between 1984 and 1999, we've had a steady decline in the number of cases. There have been fewer than 5 cases in the shelters in Boston in the last 5 years. But today, TB is a problem. There's at least 1 new person who's diagnosed with TB in the US every hour. At least 1 child under 15 is diagnosed every day with tuberculosis. Resistance to our limited number of effective drugs is increasing, and public health programs for TB are being undermined by reduced funding and misperceptions by the public and policymakers about the importance of TB as a disease in our country and the world. Here, we know it's a worldwide epidemic. As I mentioned, 25% of the world's population is infected, and 5 to 10% will develop active disease within their lifetime. 1.2 million people die from TB every year, and it's increasing worldwide, although the impact of COVID now is being recognized as maybe influencing reporting and the incidence of disease. And I'll get into that in a minute. And the whole problem of the world epidemic is made worse by the HIV epidemic in resource poor countries that lack the necessary resources and infrastructure. So this is a WHO slide that shows the estimated incidence of TB in 2018. The darker colors are the higher incidence locations, and you can see that the United States has one of the lighter colors. Our case rate is 2.7 last year per 100,000 population, as opposed to some countries like South Africa, where the case rate is well over 500 per 100,000. In the United States, based on last year's data, the rate of decline has been fairly steady since the early 1990s, when they started to reestablish the public health infrastructure for TB with federal funding. And it's been going down. It's sort of flattened out between 2018 and 19. And in 2020, along came COVID. And with it, we've had about a 20% decrease in the number of cases reported in the US in 2020. Now, the CDC has not released the numbers for 2020. I think they're being released tomorrow. But the guess that we have is that it's about 23% decrease over 2019. An increasing proportion of our United States patients come from other countries. In fact, 81% of Massachusetts TB comes from other parts of the world where TB is endemic. And more than 50 countries are represented in our caseload every year. And TB is a disease of the disadvantaged. Blacks, Asians, and Hispanics have case rates of 20, 26, and 10 per 100,000 versus 0.4 per 100,000 white US-born persons. Among the US-born, Blacks have 6 to 7 times the incidence of TB as white people do. About 5% of our cases have HIV, and multi-drug resistance is fairly uncommon due to our public health processes, but it does occur in about 1.5% of our culture positive cases in Massachusetts. So since the increase in the early mid-90s, there's been a slow decline. In 2019, there were 8,920 cases of TB reported in the US, so 2.7 per 100,000. And there are fewer than 600 deaths. So our case rate is less than 3 per 100,000. It's 2.7. And it's going to be less this coming or last year, 2020, because of factors that are likely related to the COVID-19 epidemic that are complicated. And I don't have time to get into. So we deal with TB though, not as well as I'd like to. There are new tools. We're still using the tuberculin skin test that was developed more than 100 years ago, but there are now new blood tests that are available to detect TB infection. They've got their problems, but we use them. The diagnosis of disease is facilitated by techniques that the laboratory has developed, where I believe most of our progress has been made in tuberculosis in the past 20 years. Treatment involves standard of care being patient-centered case management, where each patient is managed by a case manager to make sure he or she gets appropriate treatment with appropriate drugs and completes that treatment safely. There are at least 6 new drugs already or in human trials, and there's a standard regimen now that's 6 months for most cases of TB treatment. The CDC Trials Consortium has just come out with results of a study they're presenting about the effectiveness of a new 4-month regimen for treating active tuberculosis will be groundbreaking. Prevention involves either 9 months of INH instead of 12 as it was, or there are shorter regimens that are 3 or 4 months long that are safe and effective. But still, we're still flying in obsolete jets here. There's a lot of progress to be made. Clinical case management, as I mentioned, is critical. In Massachusetts, we were one of the pioneers for setting this up, and it's the system that delivers medical, nursing, outreach, and social services to ensure that all suspected and confirmed cases are appropriately and effectively treated. Our system in Massachusetts uses strong collaboration between our state and local public health nurses, our state epidemiologists, our laboratory, and clinicians to effectively manage our patients with the involvement and close work with our outreach education programs to bring trust and understanding to the diverse populations we have to deal with. TB control and elimination requires public health. Problem is the source of expertise is falling behind. TB is not being taught effectively in schools of medicine and nursing. We need stronger epidemiologic programs to identify outbreaks and define answers to our problems. Our state TB laboratory is a stalwart against tuberculosis, but it requires unique specialized services, including testing for drug resistance and molecular testing. we have to provide the medicines to our patients at no cost, especially if they can afford copays or deductibles. We have to use a case management program to assure safe completion of treatment. And we have to conduct contact investigations because when we find a case of infectious tuberculosis, we have to identify those people who may have been infected by that person and get them evaluated and treated to see if they have TB themselves or TB infection that needs to be treated to prevent TB in the future. And most important task, I think, beyond treatment is to engage our populations and communities at risk, our non-US born populations, our populations who live in the streets and shelters, to address and solve the divergent beliefs and health practices we encounter when we treat individual patients with tuberculosis. Tuberculosis and public health are personal. It's something that's not available in the private sector. But our infrastructure is in jeopardy. The reduced overall incidence we've been seeing drives the perceptions that TB is going away once again, like it did in the 1970s. It has become basically a disease of the disadvantaged. Like I mentioned, 80% of our cases in Massachusetts last year were born in other countries. Program funding has decreased over time, and 21 states showed increases in TB incidence between 2018 and 2019. Our experts are getting older. Sometimes I think I am too. Drug resistance complicates things further. We are lucky that we now have some molecular testing in the laboratory to help us more rapidly identify drug resistance again on top of it. And we need strong partnerships with our federal partners to collaborate in our common efforts against TB. And a major problem, a major issue that I see is that we don't have the right tools. It's basically our fault, and it's a consequence of underfunded research. We need basic research because we really don't have a good understanding of the relationship between the human and the organism. We need clinical and translational research to help us bring our concepts of the host organism relationship to trials and treatments. We need alternative treatments, vaccines or immune modifiers. The bacteria are very smart. We've identified new drugs, and as soon as we start using them, the bacteria develop resistance. And we have limited drug alternatives. We need to encourage drug development and avoid drug shortages. This slide shows the division of TB elimination funding at the CDC between 1967 and 2000, where in the face of declining TB cases, shown in as the line here, where federal funding for TB programs was wiped out in the mid-1980s or 70s and was restored in the early 90s. We now have a TB budget for the CDC in 2020, as I showed on the bottom, of $135 million. Now, that's roughly the equivalent of $77 million in 1994 dollars here on the slide. It's hardly enough to do what we need to do to control tuberculosis. So the problems we face are common to all of us. Decreases in federal and state funding, forced priorities, including reduced staffing, training and education programs get eliminated, so we don't have the expertise we needed, and there's little importance regarding case management. There are increasing barriers as people come to us from parts of the world with different concepts of prevention and disease, and frankly, concepts about tuberculosis specifically that are contrary to our practices and beliefs. We're seeing loss of access to patients at risk, fueled further by the COVID epidemic, and the loss of access by patient to our clinical and public health resources. on top of that, we're seeing more complicated cases and more drug resistance. So tuberculosis is a complex disease. Go back to the 1900s when we were mired in tuberculosis, and we've come a long way, but not far enough. And I want to thank you very much for your attention.
Thank you, John. It was a great overview of tuberculosis and policy considerations. And I want to acknowledge the presence of a number of public health nurses who play a key role, if not the key role in, and I think it is the key role in TB control from the public health standpoint, and welcome them to this. And we do have a question. Put your questions in the Q&A or in the chat, and because I can move between them. We do have a question, and I'm not surprised. It's an IGRA question, and it's do you have a preference between quantiferon versus T-spot?
Well, I have a preference. No. These are complicated tests. They involve taking blood out of somebody, keeping the blood cells alive, and then taking to a lab and testing them while the blood cells are alive. And they're subject to a lot of manipulations. They're equally useful, and I use them as I would any test. It's just a test. You have to use them in the context of who you're using it in and what you're using it for. So basically, I really have no preference one versus the other. Just have to take the results and interpret it in the context of why you ordered the test.
Okay, another question. This question is actually for Kathy Herson. Is there evidence showing a correlation between populations with high mortality rates from COVID and risk for TB disease or infection?
Well, that's a complicated question, which has probably, Kathy, a complicated answer, and which we're pretty ignorant of. We're just starting to understand or see some of the outcomes of COVID itself, COVID complicated by the treatments, because don't forget, we use immune suppression, including steroids and IL-6 blockers to treat COVID, and how that translates to risk of tuberculosis. We don't know yet. We're putting together studies to look at that across the country, and the National TB Controllers Group has a study they're working with CDC on to examine that data. But we really don't know. I've had patients develop COVID and then come down with tuberculosis afterwards. Yes, and so we just don't know what the numbers are or what the precise risks or correlates are.
A question now, Steve Brecker asks, are you aware of any rapid, inexpensive, accurate, innovative tests that are coming down the line, breath tests, other kinds of tests for, I guess, for TB infection or TB disease?
There's progress being made in the laboratory in diagnostics. One test that I'm thinking of is the urine LAM, liporabinomannan test, as a diagnosis for TB. For some reason, it's effective in persons with HIV and low CD4 counts. I'm not sure where we are in terms of getting it done and out into practice, but and in the general population, it doesn't seem to have that effectiveness. But we're looking at things like specific biomarkers to be able to tell who among the infected population is at risk for developing active disease. We're looking at biomarkers as a way of deciding the results or the outcome of our or monitoring the outcome of our treatment regimens. But these things are all in progress, and there's nothing really out there right now besides what we have.
This question from Edie Ablavsky. Why is the vaccine not used in the US?
Well, the vaccine is used basically in high incidence countries. And it's, like I say, it's useful to prevent disseminated TB or the bad kind of TB, TB meningitis in young children and infants. In low incidence areas like the US, there really is no need for this. So we don't use it. You can argue that it is not effective in other parts of the world because the places where it's used are the places that have the highest rates of tuberculosis in the world. But again, it does have some effectiveness in protecting young children. And there are studies that show that it does have some effectiveness in the specific immune response of adults to tuberculosis, if it doesn't affect the population incidence of disease. So it's an interesting question. There are questions about the possible effectiveness of the vaccine for TB, since the native disease doesn't necessarily protect you from getting TB again. That is, you can be infected with the same or with TB multiple times. We need to be circumspect about the type of vaccine you want. Do you want a vaccine that's going to prevent you from getting infected with TB from somebody else? Do you want a vaccine to prevent you from developing TB if you're infected already? Or do you want a vaccine that will act as a biologic response modifier that will help the antibiotics and your immune system clear TB if you become sick with it? And there's work being done in all those areas.
Paul Johansson asks, how did you manage to get TB rates down at Pine Street?
Barbara McGinnis, and Healthcare for the Homeless. Those guys are great. We did a lot of education. We did a TB clinic at Pine Street, one or two nights a week. In fact, during the outbreak, we were there some weeks 3 nights a week. We brought an X-ray machine into Pine Street because these guys wouldn't go down the street to Boston Medical Center or to New England Medical Center to get an X-ray. So we would take the X-rays there, and we read them ourselves. And we had a dedicated program. The nurses there were phenomenal in dealing with the patients. The patients had an open door to our clinic, and we developed a very good relationship with them because we had the support of Barbara McGinnis and the staff there. And that's key. In order to engage a population like this, you need to be able to develop trust and understanding, and understand their priorities, and treat people with respect.
Yeah, one of the most impressive people I've ever met, Barbara McInnes. She was remarkable.
Yep.
Another question from Edie Ablavsky is DOT, directly observed therapy. If that is the standard of care, does it mean each medication dose must be watched by a professional?
Yes, that's a good question. DOT is a tool, and it's used to make sure that the person takes the medicine appropriately and safely, because during each visit, the patient is observed and they're engaged. So you find out if they're having side effects, if they're looking ill from something that might be an adverse effect of the drugs. So it's standard to do this. Now there are new methods that are being used, and we're using them too, that involve electronic monitoring, like video monitoring of people taking their medicines. And there are studies that show that it's as effective as doing it in person. But you need to have that personal touch. That said, once you develop an understanding with the patient and you realize that the patient understands the importance of taking their medicines, then you can back off on that and do self-administered therapy with periodic reminders. People who are very ill with TB start taking their medicines and they can start feeling better within 1 or 2 weeks. And when you tell them they have to keep going for another 6, 12 months, they balk. They're going to balk. It's natural because you're giving them a fistful of medicines that don't make them feel good. And they forget that they were sick. So you need to maintain that relationship with the patients. And that's where nurses and outreach staff are so important in doing this.
Okay, we have 2 more questions, but I want to point out that in the chat now is a link to a post-event survey. We want to collect information that the museum can use for future programs, etc. So if people are still on, and most people are, could you click on that and fill out that form? You'll also be receiving an email. I know there was some difficulty logging in. This presentation has been recorded, and you'll be receiving an email with the survey link as well, and with a link, or at least how to access the recording. So in Russian prisons, there was a major concern about drug-resistant TB. Have new drugs eliminated that problem? And also, more people are living with AIDS. Why has this not resulted in increased TB? From Shelley Henderson.
Well, both very good questions. I've been to Russia and I've seen some of the problems there. There are infrastructure issues. And in fact, I saw a young woman who had bilateral thoracoplasties, that very disfiguring surgery that had recently been done there. Yeah, there's a lot of drug resistance there because of infrastructure issues, medication issues. And I don't know the current status in Russia at this point. And the question about the AIDS, there is very, very much effort has gone into funding and supporting the AIDS programs to do TB screening and treatment for infection. And so as those public health programs have evolved, recognizing the importance of prevention and treatment in this population, that's where we've made our progress.
I think that's it for the questions. Thank you very much, John. It was a great program for World TB Day. I want to remind people that the museum outside tours will be starting soon, that there'll be a link. There's a link in the chat you can still go to, and you'll be receiving an email in follow-up to this program. And I think that's it. Thanks again, John. And
well, thank you. Thank you for having me.
And good night, everyone.
Good night and be safe.